not too sure what the answer is. So, but there was a great first opening lecture. So we're going to move track a little bit now to Professor Ikari's talk on COVID-19 and STEMI management. Professor Ikari, please.
Yeah, thank you very much. This is a great honor to be joined this meeting. And my talk is about the COVID-19 influence, the management strategy. But probably I have worked as the president of a Japanese Association of Cardiovascular Intervention Therapeutics. It is called CIVIT. But before COVID-19, let me introduce myself. I am an inventor of Ikari guiding catheter, probably you know. And recently, the paper was accepted by CCI May this year. The title is Reduction of Door-to-Balloon Time in Patients with ST Elevation MI by Single Catheter Primary PCI Method. This is a Ikari catheter used as a right and left. So probably using the diagnostic catheter, you can skip several steps. We enrolled 1,275 patients. It's a retrospective study, but the door-to-balloon time is significantly shorter in this method. And door-to-sheath time, not significant, but the sheath-to-balloon time, it was significant. So I want to move to the COVID-19 talk. We Japanese first encountered COVID-19 at Diamond Princess ship. It was last year, February 3rd. And total of 3,700 people live in this ship, and 700 people suffered COVID-19 and 14 died. And our university sent a doctor, infectious disease specialist to this ship, and some critical patient we received and take care of that patient. And after that, it was February last year. In Japan, we have 1, 2, 3, 4 waves, and now it's the beginning of 5th wave. And also bad thing is we have an Olympic game 2 weeks later. We have a good Olympic game, but we are concerns about the pandemic, more patients of COVID-19. And first, last year, March, April, lack of protective equipment, it was a big trouble. So cap, mask, gowns, and admission beds are lacking, and all the staffs are exhausted. So lack of protective equipment was a very big problem. So if you do it without protective equipment, you will infect yourself and create a cluster that results in not saving the next patient's life. However, if you do not PCI for STEMI due to lack of equipment, the media, newspaper, TV, they are very bad, and they will report that the hospital has abandoned its patients. So save lives of medical workers and save lives of patients, that balance was very important. Actually, in Japan, we are primary PCI country. We have done many primary PCI. This is overall male, female, and every decade of the patient, 40, 50, 60 years old. This is a 24 hours mortality rate is actually lower with the primary PCI. And also, this is a very interesting data. X-axis is a PCI rate, 70, 80, 19%. And this is an in-hospital mortality rate. And if you do many PCI, the mortality rate is lower, but the rate is low, mortality rate is high. It's a significant correlation. However, bypass rate, there is no correlation. So PCI was very important. Also, we know early PCI is the best treatment for STEMI because early TPA, early PCI, it's double, 2 times difference between these treatment. So we'd like to suggest primary PCI, but the COVID-19, we suggest all the hospitals in Japan. So if you can do primary PCI if you have PPE. But without PPEA, thrombolysis is a treatment. So you can choose. But our colleagues read this statement, and my intention is you should do primary PCI between the lines. Also, the other problem is door-to-balloon time. In Japan, door-to-balloon time less than 90 minutes is a condition for the reimbursement plus 100,000 yen. It's big difference. So patients come to 12 hours, and within 90 minutes primary PCI, we can get higher cost. And before COVID-19, 88.7%, we did within 90 minutes, and median time is 42 minutes. So it was good. But after COVID-19, in some cases, you do CT radiography, you do PCR, and you wear PPE. So it takes time. So COVID-19 screening and PPE takes time. It's a problem. This is in our university hospital data, 20 minutes longer. And this is a Kanagawa prefecture data, 7 minutes longer. So it was a big problem. Actually, this is a first wave condition. Last year, March, April, May, we did an ankate analysis, and many Japan hospital answered, this is an elective PCI. Many hospitals postponed, red color is postponed. And as usual is about 50%. However, primary PCI for STEMI, more than 90% hospitals did the primary PCI for STEMI patients. And after that, this is a recent analysis, February 2021. There are some limitations. It is a 40%. 60% is no limitations. And also STEMI treatment strategy, recently it's almost 98, 99% we can do primary PCI. So this is a recent data. Blue color is as usual. So it's we are accustomed to treating COVID-19 patients and STEMI patients, zoning, and also wearing PPE. And but many people have complaints about the PCI with full PPE. Face shield fogged up, making it difficult to maintain vision. Hot and thirsty, and difficulty in maintaining concentration. So, and there are some guidelines. This is from the United States, and this is from Europe. And CBIT from Japan, we published a position statement about how to protect yourself and how to protect patients from COVID-19. And you can download this paper freely, so please see this paper. And we learned a lot about dressing and doffing of the PPE. Doffing, taking off the PPE is very important. There is a high chance of infection when you dress off the PPE. And we also mentioned about how to do primary PCI. Operating staffs wear a full PPE like this one. And in summary, primary PCI is the best treatment for STEMI. However, it may increase the risk of COVID-19 infection to medical staffs. Infection control methods, including PPE, zoning, sterilization, are essential. COVID-19 testing is up to the prior probability. PCR or CT scan is necessary in high probability patients. If it is impossible to perform full infection control, thrombolysis is considered instead of PCI. In Japan, primary PCI was maintained above 90%. So thank you very much.
Thanks, Prof. Ikari. That was excellent as usual. And I do use a lot of Ikari Left 3.5 for my primary PCI to save time. You should call it a primary PCI Ikari catheter instead. I think that helps. Can I listen to whether there's any questions or comments for Professor Ikari's talk? Yes, Fahim, you may start first.
Dr. Ikari, thank you for the talk. I'm just curious, in your experience with COVID-19 and STEMI, did you notice any difference in terms of either severity of thrombus or intensity of illness in the patients? The US has reported a lot of that. We didn't see that much in Singapore, so I'd like to hear your thoughts on that.
Yeah, thank you very much. Very, very good question. Actually, we don't have much patients. Yeah, from the United States, many patients reported that thrombotic occlusion of coronary artery. But actually, we have more patients with myocarditis due to COVID-19. So in case of ST elevation, we have to differentiate myocarditis and myocardial infarction. So sometimes we suggest echo before getting into the cath lab. For we find the asynergy, we should do the catheter, but the diffuse disorder of the myocardial motion, in that case, sometimes myocarditis. So it's different from the United States in Japan.
Okay.
Any other comments or questions from my colleagues in the panel? Before I ask Dr. Ikari also, last year and maybe perhaps this year, there's some dropping of reported ACS cases. Did you actually have any observed increased mortality when the cases did drop last year?
Yeah, good question. From the US, from Europe, MI patients reduced last year, April, May, around that. In Japan, we observed the same condition. Patient didn't come to hospital between the April to August. But in September, the number came back to normal, the same level as the last year. So probably the patient has a chest pain. They stayed in home and they did not come to hospital. So probably the mortality rate may be higher, but we don't have the data about the in-house mortality. Probably it happened, but it's normal after last year September. So probably we have same number of primary PCI in Japan.
Thanks, Prof. Ikari. There's a question from the panelists. Maybe you can take that as well. Do you have a proportion or the data on STEMI mimics in COVID patients? How often do you find no obstructive coronaries in patients with STEMI, i.e. they are more myocarditis? Do you have this data?
Actually, myocarditis, myocardial infarction, the comparison is my impression. I don't have a data, but we asked our colleagues to report the definite COVID-19 plus myocardial infarction cases. The number is not so big, and myocardial infarction is actually it's a myocardial infarction without fever, without cough, like that. So that's my impression, and not so many, not on based on the data.
Yeah, so is there any last questions for Professor Ikari?
Yeah, I have a question, Dr. Jack.
Yes, please go ahead.
Okay, first I give a special thanks to Ikari because he is the APSC nominated speaker. We are really glad to have him. My first question to him, actually, in COVID pandemic situation, we really face difficulties to treat ST elevation MI. As you know, you nicely mentioned ST elevation MI and myocarditis is the big difficult problem, but I think type 1 and type 2 MI is most make us very conflicting situation, whether it is we go for primary PCI or not. So in that situation, how can you clinically assume it is type 1 or type 2 MI?
Yeah, actually, it is very difficult to differentiate type 1 and type 2 MI without coronary angiography. So in many cases, we have to do the coronary angiography to differentiate these patients. So in the COVID-19 era, there's a myocarditis, type 1, type 2. So we have to do the coronary angiography. So now we are accustomed to wearing PPE. So in many cases, we send the patient to the cath lab.
So this is the final answer to after going cath lab, then we can differentiate whether it is type 1 or type 2 MI. Before that, we have to take a decision, go for primary PCI strategy, right?
Right. Yes.
Thank
Okay,
you.
thank you,
Thank
Jack.
you, everyone. Yeah. So COVID-19 indeed puts a strain on cardiologists in treating our patients. But I'd just like to say that please don't deviate too much from current guidelines in terms of how we treat our patients. In my country, especially, although we considered thrombolysis, we didn't stop doing primary PCI for all patients, and that really helped a lot. So I think the message is that don't deviate too much from our current evidence-based practice in cardiology.